Hello guys, welcome back to the Unacademy NEET PG live channel. I am Dr Himanshu Gupta and I have done my MBBS and MD from Maulana Medical College. So guys, today in this lecture we are going to discuss a few important images from the section of hepatobiliary imaging and gastrointestinal radiology. Right? So guys, let us begin. I will be showing you important spotters and also I will be showing you the normal CT anatomy as well, ठीक है? तो शुरू करते हैं. Let us begin. Let us wait for few friends to join and then we can begin. So just say hi to me if my voice is clear to you guys. If my voice is clear to you guys. Is my voice clear to you? Is my voice clear to you? ठीक. Okay, great. So now guys, let us begin. I'm going to begin with these three images, right? So what you are going to do, you are going to help me identify in which phase these images have been acquired. Okay, so I'm showing you three images, A, B, C and E. Okay, so I'm also giving you few options: non-contrast, arterial, venous and delayed phase. Okay, so within these options you have to help me. Okay, which are the images that have been shown to you? Within these options you have to help me out which are the phases which are being shown to you in these sequences. Okay, so we will start by learning to understand the various phases. We will start by learning to understand the various phases on a triple phase CCT abdomen. Right? So let us see who is able to identify the various phases. ठीक है? Anyone guys? Anyone? So guys, in the first image you can see that if you look at the aorta and the IVC, both of these, okay, they have similar enhance. Okay, they have similar attenuation. And their attenuation matches that of liver and the spleen. Okay, their attenuation matches that of liver and spleen. So an image in which your aorta and the IVC, they are appearing hypodense and they are having similar enhancement as that of surrounding organs. Okay, so that image guys you are going to label it as a non-contrast image. Right? So looking at the second image guys, in this image we can see, if you look at the aorta, okay, aorta is avidly enhancing in this case, right? And it is enhancing more than your liver and the spleen. As compared to IVC also, this aorta is enhancing. So if you are going to look at the hemangioma, right? If you look at the hemangioma, you will see that this hemangioma, it is going to show a peripheral nodular enhancement. It is going to show a peripheral nodular enhancement in the arterial phase, and in the portal venous and delayed phases, it is going to show progressive enhancement. It is going to show progressive enhancement, right? So guys, these are the important features, and these are the few tumors for which triple phase CECT abdomen is done. For which triple phase CECT abdomen is done, right? So this is an important question that is asked in your surgery as well. That is asked in your surgery as well. So you guys should be able to identify the various phases. Okay, you guys should be able to identify the various phases. Okay, so how is this triple phase CECT abdomen is acquired? How is this triple phase, okay, CECT abdomen acquired? So guys, what happens? Okay, we are going to give this IV contrast to the patient. Okay, we are going to give this intravenous iodinated contrast to the patient, and then what we are going to do? We are going to acquire the scan between 20 to 30 seconds. Okay, when we acquire the scan between 20 to 30 seconds, this is going to give us an arterial phase. This is going to give us an arterial phase. When we are acquiring the scan, okay, at 60 to 70 seconds, when we are acquiring the scan at 60 to 70 seconds, it is going to give us the portal venous phase. It is going to give us the portal venous phase. Okay, and at 3 to 4 minutes, we are going to get this delayed phase. All right. So guys, these are the various phases. Okay, uh, that we acquire in a triple phase CECT abdomen. So now guys, let us have a look at the normal anatomy, normal CT anatomy of the abdomen. Okay, so before I begin with the normal CT anatomy of the abdomen, okay, let me tell you guys, there are two structures, okay, which are going to appear black on CT, okay. So remember these two structures, these are your fat, okay. If you have a look at this image, you will see that the subcutaneous fat in this CT abdomen image, it is appearing black. And the second structure which appears black on the CT image, that is your air, okay. So these are the two structures which are going to appear black. Okay, very good Nisha, So these are the two structures which are going to appear black on a CT image, right? Now guys tell me, the first image that I'm showing you, these are the sections at the uppermost part of the liver, okay. So here you can see that these are your lungs, which are appearing black, okay. Then this is your upper part of the liver, and this is your IVC, with the three hepatic veins, draining into the with the three hepatic veins draining into the liver, right? So guys, here I can also ask you one more important question, okay, the structures, okay, crossing the diaphragm from the thorax, so can you help me with this? IVC crosses the diaphragm, at what level? Anyone? IVC crosses the diaphragm at what level? Anyone, guys? IVC crosses the diaphragm at what level? Anyone in the comment section who can tell me IBC will cross the diaphragm at what level? It crosses the diaphragm at T8 vertebral level. T8 vertebral level. Okay, along with right phrenic nerve. Along with right phrenic nerve. Okay. So this is your IBC. This is your IBC crossing your diaphragm at the T8 vertebral level. T8 vertebral level. Right. Then your aorta. Aorta. This is your aorta. This is your aorta. Can anyone tell me aorta crosses the diaphragm at what level? Aorta crosses the diaphragm at what level? It crosses the diaphragm at T12 vertebral level. T12 vertebral level. Okay, along with a zygous vein, and thoracic duct, along with a zygous vein and thoracic duct. Okay, and very good, very good. And tell me your esophagus. Okay, esophagus crosses the diaphragm. Okay, esophagus crosses the diaphragm at what level? Anyone, guys? Esophagus crosses the diaphragm at what level? Esophagus crosses the diaphragm at what level? Very good, Nisha. Okay, so your esophagus is going to cross the esophagus at T10 vertebral level along with both the vagus nerve, Okay. So guys, these are the various structures which are going to cross the diaphragm. Okay. Now let us talk about the Coinard segments of the liver. Okay. So guys, we all know your liver, it is divided into right and left lobe. Liver is divided into right and left lobe. Okay. So which is that vein which is going to divide the liver into a right and a left lobe? Which is that vein which is going to divide the liver into a right and left lobe? Anyone? Which is that vein which is going to divide the liver into a right and a left lobe? Okay, so guys, this is your middle hepatic vein. Okay, it is your middle, not IBC, it is your middle hepatic vein, which is going to divide the liver into a right and a left lobe, right? Then guys, we have the right hepatic vein. Okay, so we have the right hepatic vein. This right hepatic vein, guys, it is going to divide the liver, okay, into anterior and posterior segments. So these anterior segments, these include your segment 5 and segment 8, and your posterior segments, these include your segment 6 and segment 7. And if we talk about the left hepatic vein, okay, so this left hepatic vein, it is going to divide the liver into a medial and a lateral segment, So medial segments include segment 4A, segment 4B, and lateral segments include segment 2 and segment 3. Okay, so this is the basic normal anatomy of the liver. And if we talk about the structure which is dividing the liver into superior and the inferior segments, this will be your portal vein. Okay, this will be your portal vein. Okay, so portal vein will further divide the liver, okay, into superior and the inferior segments. Okay, so portal vein is further going to divide the liver into superior and the inferior segments. Okay, so guys, tell me now what I'm going to do. I'm going to label few structures and you are going to help me identify those structures. Okay, you are going to help me identify those structures. This is the structure A guys, structure B, ठीक है, C, D and E. Try to label the structures that I have shown to you in this image. Try to label the structures that I have shown to you in this image. Anyone? Anyone? Try to label the structures that are being shown to you in this image, guys. So let me tell you, okay, let me tell you. So guys, the structure A that you are seeing here, an enhancing structure A that you are seeing here, enhancing structure A that you are seeing here, this is your, anyone, this is your, what is this structure guys, anyone? This is your portal vein, this is your portal vein, right? So this structure B, this is your stomach, this is your stomach, this is your stomach, ठीक है? So the structure that is seen just behind the stomach, the structure that is seen just behind the stomach, okay, this is your pancreas, this is your pancreas, right? This is your pancreas. The structure just behind the stomach is your pancreas, labeled as C in this image. And the structure labeled as B, the structure labeled as B is your spleen. The structure labeled as B is your spleen, and the structure labeled as D in this image, the structure labeled as D in this image. Anyone? What is the structure labeled as D in this image? What is the structure that is labeled as D in this image? What is the structure that is labeled as D in this image? No, D is not gallbladder. D is not gallbladder. The structure labeled as D in this image is your descending colon. Descending colon. Okay, so it is basically your splenic flexure. It is basically your splenic flexure. ठीक है? Splenic flexure, and you can see these are your two kidneys that are seen, okay, on either side of the vertebra. These are your two kidneys that you are able to see on either side of the vertebra. Now coming to few sections lower down the above section, here we can see guys, here we can see, chalo, first you can try to identify A, B, C and D. Try to label all these structures, guys. Try to label all these structures. A, B, C and D. Okay. Try to label all these structures. So I'm waiting for you guys to write down the answers. Okay, I'm waiting for you guys to write down the answer. So guys, the structure labeled as A in this image, the structure labeled as A in this image is your gallbladder. Okay, the structure labeled as A in this image is your gallbladder. Okay, so just remember that this gallbladder is a fluid filled structure, and this is how your fluid filled structure will look like. And also guys, also try to appreciate the walls of the gallbladder. Also try to appreciate the walls of the gallbladder here. You can see that the walls of the gallbladder, guys, walls of the gallbladder, they are very thin here. Okay, and if the wall thickness of the gallbladder, if the wall thickness of the gallbladder is more than 3 mm, I will show you that case also in which the walls of the gallbladder are more than 3 mm in thickness. In that case, guys, you are going to suspect a case of acute cholecystitis. In that case, you are going to suspect a case of acute cholecystitis. Okay. And if you look at the image B, if you look at the image B, in the image B, you can see that your this is your stomach. B is your stomach, okay, and yes, B is your stomach, and it is filled with positive oral contrast, and the stomach, it is filled with positive oral contrast, right? The stomach, it is filled with positive oral contrast, right? And if you look at the structures C and D, okay, C is part of the transverse colon, C is part of the transverse colon, and D is your descending colon. D is your descending colon. Okay. So just remember, if you will have a look at the structures, okay, if you look at the colonic loops, okay, these colonic loops, guys, you know, the contents of the colonic loops are feces, and feces, remember, are mixed with air. Feces are mixed with air. That is why what you are going to see, that the contents of the colonic loops will be heterogeneous. And if you look at the contents of the ileal loops, okay, if you look at the contents of the small bowel loops, you will see, okay, you will see that the contents are more homogeneous. Okay, so there is an importance of this which I will show you as we move ahead. Okay, if you look at the contents of the small bowel loop, they are more homogeneous, and here the contents of the small bowel loops are appearing bright. The contents of the small bowel loops are appearing bright. Why? Because, you know, positive oral contrast has been given to you, these patients. Okay, positive oral contrast has been given to these patients. Is that right? Okay, is that right? Now guys, coming to a lower down sections, here again in this image we can see this is your gallbladder. These are your jejunal loops. In the left upper part of the abdomen. Here you are able to see the descending colon. This is your ascending colon, right? So these are the various structures at this level. Okay, so what I want you guys to note, just have a careful look at the gallbladder. Just try to have a careful look at the gallbladder. So which will be the most important thing for you guys to know. Okay, because acute cholecystitis is something we are going to encounter very frequently in our daily life, right? And many of these will get a CCT abdomen done, and in this CCT abdomen, guys, what you are going to see, you will see that the wall thickness of the gallbladder will be more than 3 mm. Okay, wall thickness will be more than 3 mm. Okay. Now guys, coming to few more structures. Can you tell me which structure is this on either side of the vertebra? Which structure is this on either side of the vertebra? Which structure is being shown to you that is seen on either side of the vertebra? No, this is not kidney. No, Priyanka, this is not kidney. Anyone? So I showed you that a kidney on a contrast enhanced image. Okay, you will be able to see the cortex, you will be able to see the medulla. Okay, this is how your kidney looks. Okay, so this is not kidney. This is a muscle that is going to run in the paravertebral space. This is a muscle that is going to run in the paravertebral space. Okay, this is your psoas muscle. Okay, that is going to run on either side of the vertebra. So these two structures which I am labeling in the brown color. Okay, can you label these two structures, brown structures? Anyone? Can you label these two brown structures? Okay, one is your IVC and the other is your aorta. One is your IVC and the other is your aorta. So here in this image, guys, I want you to understand, okay, how are the loops, okay, how are the loops of the small intestine appearing and how are the loops of the large intestine appearing. So here again I am repeating that the loops of the small intestine, they will have more homogeneous contents. Okay, the loops of the small intestine, they will have more homogeneous contents, and if you have a look at the loops of the large intestine, they will have a heterogeneous appearance. Okay, so now guys, labeling fluid, let us label these two structures A, B, C and D. Let us try to label these structures. Okay, let us try to label these structures that are being shown in this image. Okay, let us try to label the structures that are being shown in this image. Anyone, guys? A, B, C, and D. Try to label the structures. Try to label the structures which are being shown in this image. Try to label the structures, okay, which are being shown in this image. Which are the structures which are being shown in this image? The structures labeled as A, B, C, and D. Okay, so let me help you. Okay, the structure labeled as A in this image. The structure labeled as A in this image. A is your rectum. Okay, A is your rectum, right? The structure labeled as B in this image. Okay, so this muscle which is running on the iliac bone, this muscle which is running on the iliac bone, this is your iliacus. Okay, iliacus muscle, and together this iliacus muscle and the muscle that is just seen anterior to it, this is your psoas muscle. Okay, so we have the two muscles, iliacus and the psoas. The structure labeled as C in this image is your sigmoid colon. The structure labeled as C in this image is your sigmoid colon, and the structure labeled as D, the structure labeled as D, okay, that is your ileal loops. That is your ileal loops. Okay. So Dr. Nisha and Dr. Priyanka, are we clear? Are we clear with the normal CT anatomy of the abdomen? Are we clear with the normal CT anatomy of the abdomen? Yes or no, guys? So we started with the quinard segments of the liver. Okay, so let me just revise it to you again. Okay, this is your portal vein which divides the liver into superior and the inferior segments. This is the normal appearance of the pancreas, right? The structure that is seen, a vascular structure seen just posterior to the pancreas, this is your splenic vein. Splenic vein and splenic artery are going to run. Okay, splenic artery is going to run along the superior border of the pancreas, and splenic vein is going to run just behind the pancreas. This is your stomach. This is your descending colon, right? So gallbladder is a fluid-filled structure. This is how your gallbladder will look. Why it is important? Why? because in a patient with acute cholecystitis, you are going to see that the wall thickness of the gallbladder is going to increase, and we are going to see these patients as well. And guys, these are the two renal veins which are draining into the IBC, Okay. Then guys, we have the jejunal loops here. Okay. We have the jejunal loops here, and we can see that the valvulae conjunctis of the jejunal loops, they are more prominent than the valvulae conjunctis seen in the ileal loops. And also remember that the contents of the large bowel loops, it is heterogeneous, and the contents of the small bowel loop, they are more homogeneous. Okay. And few structures within the pelvis, guys, so guys, this is your rectum, okay, and this is your sigmoid colon, descending colon, right? So a muscle that is seen along the iliac bone, this is your iliacus muscle. Can you guys tell me the two muscles that are seen anteriorly? The two muscles which are seen anteriorly, can you tell me these two muscles? Anyone? Can you tell me these two muscles which are seen anteriorly, okay, in the which are forming the wall of the abdomen, okay, seen anteriorly? Two muscles, guys. Anyone? So many people like to show off these muscles as well. Okay, so these are your rectus abdominis muscle. This is your rectus abdominis muscle. Okay. So guys, this was about the normal anatomy of the abdomen, Now I'm going to show you few pathologies, okay, how they are going to look on the ultrasound as well as CT, few pathologies, right? So guys, beginning with the most common benign lesion of the liver, guys. What do you see here? This is an ultrasound image. So just remember that on ultrasound, what happens? On ultrasound, your fluid okay, on ultrasound, what happens? Your fluid looks black, okay, or anechoic. Okay. And within the liver, if you are seeing a hyperechoic lesion on ultrasound, okay. So let me show you few more ultrasound images. Guys. Okay. So okay, so let me just show you few more ultrasound images. Okay. So guys, if we have a look at these ultrasound abdomen images, okay, so this is how your liver is going to look. Okay, this is how your liver is going to look. Okay. And what are we seeing in this? This is how your kidney is going to look on an ultrasound, right? And let us have a look at the image of the gallbladder as well. Okay. And this is how your gallbladder is going to look on an ultrasound. Okay. So we can see in these images, okay, that your gallbladder, it is going to look anechoic, okay. And guys, what are we seeing here? We are seeing a hyperechoic lesion. And on contrast enhanced CCT abdomen, we can see that this lesion is showing peripheral nodular enhancement. Okay. So guys, what will be this case? Okay, what will be your diagnosis for this case? Anyone? So hyperechoic lesion on the ultrasound, On the contrast enhanced CT abdomen, it is showing peripheral nodular enhancement. So that diagnosis will be, okay, most common benign lesion of the liver, most common benign lesion of the liver. This is a case of hemangioma. Okay, this is how your hemangioma is going to look on the ultrasound as well as CCT abdomen image. Very good, Nishika. Very good, Nishika. Okay. So guys, this is a patient presented with clinical history of pain in the right upper quadrant. She also has history of fever for past 3 days. Okay. CECT abdomen was done. For this patient, and we could see the following lesion. Okay. Following lesion. Will a hydatid cyst present with fever? No. Okay. Fever will be unlikely in a case with hydatid cyst. Okay. And if you look at the ultrasound image of the hydatid cyst as well, guys, you are not going to see this peripheral hypodensity. In a case with hydatid cyst. So this is not a case of hydatid cyst. What other pathology? No, this is not a water lily sign. This is not a water lily sign. Not a water lily sign, guys. What else you are going to think? Okay, a hypodense peripherally enhancing lesion. Okay, seen in the segment 4/5 of liver. Okay, segment 4/5 of liver, which is showing peripheral enhancement. The patient presented with pain in the right upper quadrant and fever for the past 3 days. The lesion is already being shown to you guys. You just have to tell the diagnosis here. Anyone with the diagnosis, guys? What is your diagnosis for this case? Carcinoma, HB urea. What is carcinoma, HB urea? Anyone, guys? What is your diagnosis for this case? No, this is not gallbladder. I have already shown you. Okay. Will a carcinoma gallbladder? Okay, present with fever. Okay. Which is the pathology that you know within the liver that is going to present with fever, guys? Very simple question. Pathology that you are aware, okay, that is going to present with fever. Pathology that you are aware is going to present with fever. Anyone, guys? Very good, Vishnu Prasad. So finally I'm getting the answer that I was waiting for, guys. This is a case of liver abscess. Okay, liver abscess, pyogenic liver abscess. Amoebic liver abscess. Okay. So guys, this liver abscess, it is going to have one characteristic sign that is known as double target sign. This liver abscess is going to show the sign which is known as double target sign. And guys, what is this double target sign? You will see that your liver abscess, it is appearing hypodense. Okay, the fluid content of this liver abscess, okay, is appearing hypodense. It is surrounded by a inner enhancing rim. It is surrounded by an inner enhancing rim and an outer hypoenhancing rim. Outer hypoenhancing rim can be seen. Outer hypoenhancing rim can be seen in this patient, right? Outer hypoenhancing rim can be seen in this patient. Is that clear with you guys or not? Okay, so guys, this is a case of liver abscess. Okay, and guys, in a case with pyogenic liver abscess, you are going to see multiple liver abscesses. Okay, you are going to see multiple liver abscess. Here again you are seeing that there are multiple hypodense collections can be seen in the liver, which are surrounded by a peripheral hypodensity, right? So these are again multiple liver abscesses. And guys, the characteristic of this peripherally hypoenhancing areas is that, it is going to show enhancement. These areas are going to show enhancement in the delayed phases. ये जो peripheral outer hypoenhancing rim था, that is going to show enhancement in the delayed phases. ठीक है? Okay, so guys, what do you see in this case? We are able to see what is the investigation first. What is the investigation? Anyone? What is the investigation shown to you? What is the investigation that is shown to you in this image, guys? Anyone? Very good, gamma knife. Okay, so these are your ultrasound okay, ultrasound abdomen images. And what we are able to see, we are able to see anechoic cystic lesion. Okay, with a septation within. Okay, so this unilocular cystic lesion, with a septation within, this was the case of hydatid cyst of liver. Okay, so sometimes this hydatid cyst of liver, it can present with multiloculated cystic lesion. Okay, multiloculated cystic lesion. So according to the Garby classification, this is the type 2 hydatid cyst, okay, in which you are going to see multiple locules can be seen. And sometimes, you are going to see detached membranes. Okay, so detached membranes giving a water lily appearance. Dr. Nisha. Okay, so you had answered for something water lily sign. So guys, when the membranes detached and they are floating in the cystic component of this hydatid cyst, in that case you are going to call it as a water lily sign. This is type 3A. According to Garby classification. And what is type 3B? In type 3B, you are going to see mixed solid cystic lesion. You are going to see, and you are going to see daughter cyst as well. Okay, so guys, this is how your solid component looks like. This is how the cystic component looks like, and these are your few daughter cysts that are seen within this hydatid cyst. Type 4 is your heteroechoic appearing lesion. Okay, will be your, again, it can mimic some tumor as well. Okay, so just remember, a tumor will show some internal vascularity, whereas your hydatid cyst, it is not going to show. Hydatid cyst is not going to show any internal vascularity. hydatid cyst is not going to show any internal vascularity. ठीक है, right? Clear? So here again guys, this is a case of triple face CECT abdomen. Okay, this is a case of triple face. So before I show you this case, also tell me guys, what is the treatment? What is the treatment for hydatid cyst? Anyone? Treatment for hydatid cyst? Treatment for hydatid cyst of liver. Treatment for hydatid cyst of liver. Anyone? Anyone guys? Treatment for hydatid cyst of liver. Treatment for hydatid cyst of liver is pair procedure. Okay, pair procedure. Pair procedure. Yes, first pair procedure. Okay, percutaneous aspiration. Okay, and injection of this colicidal agent and re-aspiration. What is this colicidal agent that we are going to use? What is this colicidal agent that we are going to use? Anyone? Scolicidal agent that we are going to use. Anyone? Okay, we are going to use hypertonic saline. Hypertonic saline we are going to use, right? So these are few points about the hydatid cyst. So now guys, I'm going to show you another case. Triple face CECT abdomen is shown to you. This is your arterial face. This is your arterial face. ठीक है, in which you are seeing that aorta is showing very intense enhancement. Then you cannot see any IBC. Then these are your portal venous face. Okay, because aorta and IBC. वॉल्यूम किसकी है? वॉल्यूम किसकी बढ़ाओ? I think the volume is fine. ठीक है, so the volume is fine. So guys, now have a look at this case. This is a case of a triple face CECT abdomen. And what is being shown to you in this triple face CECT abdomen? Anyone? What is being shown to you in this triple face CECT abdomen? So guys, we can see that on the arterial face, right? On the arterial face, this lesion is showing peripheral nodular enhancement. On the arterial face, guys, this lesion is showing peripheral nodular enhancement. Is that clear? And on the portal venous and delayed phases, we can see that the lesion is showing progressive enhancement. On the portal venous and delayed phases, we can see that the lesion is showing progressive enhancement. ठीक है, the lesion is showing. Okay, the lesion is showing. Hi Dr. Neha. So the lesion is showing progressive enhancement. So guys, hi Yashashvi Pant. Okay. So guys, now can you help me with the diagnosis? Okay, this is again the most common benign lesion of the liver. Okay, so guys, can you tell me a most common benign lesion of the liver? This is the most common benign lesion of the liver. Anyone? This is the most common benign lesion of the liver. So guys, this is a case of Dr. Gamma knife. Dr. Gamma knife. No. The lesion is showing peripheral nodular enhancement in the arterial phases, and if you see this part, this is showing progressive enhancement. This is showing progressive enhancement in the portal venous and delayed phases. This is showing progressive enhancement in the portal venous. Hi, I'm Dr. Sai Praveen Harnad. Portal venous and delayed phases. Any guesses, guys? Any guesses? So guys, this is a case of hemangioma, right? This is a case of hemangioma of the liver. Okay, this is a case of hemangioma of the liver. Is that right? Is that right? This is a case of hemangioma of the liver. Okay. Now guys, moving on to few other images. In this image, we can see that there is a iso-enhancing lesion. Iso means it is having a similar enhancement as compared with that of liver parenchyma. The lesion is having similar enhancement as compared to that of adjacent liver parenchyma, and we can see that within this iso-enhancing lesion, there is a central non-enhancing area within. Central non-enhancing area can be seen within this lesion. Okay, so this central non-enhancing area, this is your central scar appearance. Okay, this is your central scar which can be seen within this lesion. And guys, we all know, okay, we all know the central scar. The central scar, guys, it is seen in the central scar, guys, it is seen in which case? You are going to see central scar in a case of focal nodular hyperplasia. Focal nodular hyperplasia, which is the second most common benign tumor of the liver. Which is the second most common benign tumor of the liver. So other lesions which are going to have this central scar, okay, appearance, which are going to have this central scar, these include your renal oncocytoma. Okay, then you have your serous cyst adenoma of pancreas. Okay, and what else? You have your fibrolamellar variant of HCC. Okay, which is going to have central scar appearance. Okay, central scar sign, right? Then guys, this patient had history of alcohol intake. Okay, so I will just enumerate the features for you guys. This is a patient of chronic liver disease, and what we are able to see in this patient with a chronic liver disease is that we are able to see this irregular nodular outline of the liver can be seen. We can see that there is atrophy of the right lobe of liver, atrophy of the right lobe of liver, and hypertrophy of the segment 2 and 3, hypertrophy of the segment 2 and 3 of the liver. Okay. We can also see there is widening of the fissure. Okay, widening of the interlobar fissure. Fissural widening can be seen in these patients. Okay. So this is a case of chronic liver disease. Chronic liver disease. Now guys, moving on to few other images. So first of all, tell me, what are your observations in this case? What are your observations in this case? Anyone? What are your observations in this case? Very good, Dr. Kama, right? What are your observations in this case? What are you able to see, guys? What are you able to see? So guys, in this image we can see, that there are um, uh, few structures. Okay, few air foci can be seen. Air foci can be seen within the liver. In this image we can see that air foci can be seen within the liver. Air foci can be seen within the liver, right? So guys, these air foci, it is representing two things. Okay, either these air foci can be in the portal vein, either these air foci can be within the portal vein, or these air foci can be present, within the biliary radicals, or these air foci can be present within the biliary radicals. So guys, these are the two options that we have. Now guys, we have to choose. Okay, now guys, we have to choose whether this air is present within the portal vein, or whether this air is present within the biliary radicals. So now guys, if the air is reaching up to the periphery of the liver, then you are going to call it as portal vein gas. If air is reaching up to the periphery of the liver, then you are going to call it as portal vein gas. If air is seen in the central part of the liver, then you are going to call it as pneumobilia. Right? So now guys, here in this case we can see that air is seen in the central part of the liver. Air is seen in the central part of the liver. Okay? Air is seen in the central part of the liver. So this foci of air is seen within the central part of the liver. Okay? So this is a case of pneumobilia. Okay? Now guys, moving on to the next image. Guys, what are you able to see in this image? Anyone?
Playing from desktop A33F54.
What are you able to see in this image? Anyone guys, what are you able to see in this image? Very good, Nimisha Mondale. Okay, we are able to see few lesions. We are able to see few lesions. Okay, which are having which are having water density. Okay, basically these are your cystic lesions. Cystic lesions which we are able to see. Cystic lesions we can see. ठीक है. And if you appreciate, okay, if you appreciate in this image, within this image, guys, we can see multiple locules. Okay, multiple cystic locules can be seen. Okay, so these cystic lesions, okay, these are nothing. Okay, these are nothing. These are basically your hydrated cyst of liver. This is again a case of hydrated cyst of liver. Multilocular cystic lesion. Multilocular cystic lesion, guys. You are going to think of a case of. You are going to think of a case of hydrated. You are going to think of a case of hydrated cyst of liver. Hydrated cyst of liver. Right. Now, guys, moving on to the next image. Moving on to the next image, guys. Anyone, guys, anyone. Anyone, guys. What are you able to see in this image? What are you able to see in this image? What are you able to see in this image? Anyone, guys? So just look at these two images. Just look at these two images. Okay? These two images, and try to point out what you are able to see. Try to point out what you are able to see. Okay? Very good. Very good. So, guys, guys, in this image, we can see. In this image, we can see that this lesion is showing portal venous face washout. This lesion is showing portal venous face. Okay, portal venous face washout. Okay, this lesion is showing portal venous face washout. And if you look at the arterial face, in the arterial face, we can see that the lesion is hyper enhancing. The lesion is hyper enhancing in the arterial phase, and it is showing wash out. It is showing wash out in the venous phase. Wash out in the venous phase. So, guys, now can you tell me? Okay, now can you tell me what is the case? What is your diagnosis for this case that we are seeing here? What is the diagnosis? What is the diagnosis for the case that we are seeing here? Diagnosis for the case that we are seeing here. Anyone? Anyone? What is your diagnosis for the case that we are seeing here? So, guys, this is a case of hepatocellular hepatocellular carcinoma. Hepatocellular carcinoma. Is that right? Is that right? Okay. So, guys, just remember, what do we understand? What do we understand by the portal venous face washout? What do we understand by the word portal venous face washout? Okay, so in portal venous face washout, you will see that the enhancement of the liver, enhancement of the lesion, as compared to the surrounding liver parenchyma. The announcement of the liver as compared to the surrounding liver parenchyma, it will decrease. Okay, enhancement of the lesion, enhancement of the lesion as compared to the surrounding liver parenchyma, it will decrease. Okay, so this will be a case of hepatocellular carcinoma. Hepatocellular carcinoma. Okay. So now guys, we have this ultrasound abdomen image in which your gallbladder is being shown to us. Gallbladder is being shown to us, right? So what do you see? What do you see in this case, guys? What do you see in this case? In this case, we can see that there is some calculus within the gallbladder that is showing posterior acoustic shadowing. This is how your posterior acoustic shadowing looks like. This is how your posterior acoustic shadowing looks like. ठीक है? And this is another hyperechoic lesion in the gallbladder wall that is not showing any acoustic shadowing. And this was the case of gallbladder polyp. This was the case of gallbladder polyp. ठीक है? So now guys, coming to this case, what are we able to see? In this case? What are we able to see in this case? Anyone? This is the patient who presented with, okay, pain in the right upper quadrant. Okay, patient presented with pain in the right upper quadrant. Okay, so what is your diagnosis for this case? What is your diagnosis for this case? A patient presented with pain in the right upper quadrant. Okay, what you are seeing, that if you are looking at this gallbladder image, if you look at this gallbladder, you will see that the wall of the gallbladder it is thickened. Right? Wall of the gallbladder it is thickened, and we can also see pericholecystic fluid. Pericholecystic fluid can be seen around this gallbladder wall, right? And there is also a rent in the gallbladder. ठीक है? So guys, can you tell me what is this case? Thickening of the gallbladder, along with pericholecystic fluid. This was the case of acute cholecystitis. ठीक है? And guys, the gold standard investigation of choice in a case with acute cholecystitis is your HIDA scan. HIDA scan is the gold standard investigation of choice. ठीक है? And guys, what you are going to see in this HIDA scan, okay, so hepatoimmunodiestic acid is excreted in the biliary system. You will see it is in a normal patient. It is going to label the common bile duct, it is going to label the gallbladder, and after some time it is going to be excreted in the small bowel. Right? So in a case with acute cholecystitis, if you know what is acute cholecystitis, so acute cholecystitis happens when there is a calculus in the neck of the gallbladder. So जब calculus होता है neck of the gallbladder में, okay, so the contents of the gallbladder, they are not going to drain into the CBD. Okay, so in that case, you know, the agent that we are using here, hepatoimmunodiacetic acid, that also cannot enter into the gallbladder. So in a case with acute cholecystitis on HIDA scan, we are going to see that the gallbladder is not visualized. Gallbladder is not visualized. ठीक है? Gallbladder is not visualized. So guys, what is the investigation? What is the investigation that I am showing you in this image? What is the investigation that I am showing you in this image? Anyone? Anyone who can tell me what is the investigation that I am showing you? Anyone guys, what is the investigation? This investigation is your MRCP. This is the MRCP. These are your heavily titubated abdomen, heavily titubated images, okay, in which you are able to see the common bile duct, okay, in which you are able to see the common hepatic duct. This is your cystic duct, and these are your intrahepatic. This is your right and left hepatic duct, and these are your intrahepatic biliary radicals. These are your intrahepatic biliary radicals, right? So guys, in this image we can see that there is a filling defect seen. There is a filling defect seen in the cystic duct. Filling defect is seen in the cystic duct. Okay, and this filling defect, what is this filling defect doing? This filling defect, it is impinging onto the common hepatic duct and resulting in its obstruction. It is impinging onto the common hepatic duct and resulting in its obstruction, and as a result guys, there is dilatation of the intrahepatic biliary radicals, and there is dilatation of this common hepatic duct as well, due to a calculus in the cystic duct. Due to a calculus is there in the cystic duct, and it is resulting in upstream obstruction. Okay, so guys, this is a case of Mersey syndrome. This is a case of Mersey syndrome, right? This is a case of Mersey syndrome. Now another ultrasound image of the abdomen. This is another ultrasound image of the abdomen is shown to you. What are you able to see on this ultrasound image of the abdomen? What are you able to see on this ultrasound image of the abdomen? Anyone guys? Anyone in the comment section? Anyone in the comment section who can tell me what is being shown to you in this ultrasound image of the abdomen? What is being shown to you in this ultrasound image of the abdomen? Anyone guys? So guys, in this ultrasound image of the abdomen, we can see, comet tail like artifacts. Okay, comet tail like artifacts can be seen, okay, uh, within the wall of the gallbladder. So these comet tail artifacts within the wall of the gallbladder, these are seen in a case with adenomyosis of the gallbladder. These are seen in a case with adenomyosis of the gallbladder, right? And guys, what is going to happen in the adenomyosis of the gallbladder? Okay, what is going to happen? Okay, there is there is hyperplasia. There is hyperplasia of the wall of the gallbladder. Hyperplasia of the wall of the gallbladder. Okay, with formation of Rokitansky-Askov sinuses. Okay, Rokitansky-Askov sinuses. ठीक है, right? So another important MRCP image. Another important MRCP image, guys. Anyone? What are we able to see in this MRCP image of the abdomen? What are we able to see on this MRCP image of the abdomen, guys? Anyone? No, this is not an aneurysm. Okay, this is the MRCP image of the abdomen in which you are able to see the biliary radicals. Right? So tell me, what are you able to see? Double duct sign. No. Is audio not fine? Is audio not fine? Audio not fine? Audio is not good. Dr. Teja Kumar, is there any problem with the audio? No, this is not double duct sign. Nimisha, in double duct sign you are going to see dilated CBD. Not audible. Let me just check. You can use your earphones. Okay, you can use your earphones for better audio, because I can hear the same thing on my mobile phone, right? So cannot help it right now. Okay, so I will definitely check it in the next session, but right now you will have to. Right now I cannot do anything about the voice. So guys, in this image what is happening, there is fusiform dilatation. Seen. Okay, there is fusiform dilatation seen in the common bile duct. Okay, there is fusiform dilatation seen in the common hepatic duct. Okay, so guys, this fusiform dilatation, okay, this fusiform dilatation of the common bile duct, fusiform dilatation of the common hepatic duct, guys, extrahepatic biliary system. This is a case of choledochal cyst. Nimisha, just remember that in a case of double duct sign, okay, let me show you the double duct sign as well. Okay, let me show you the double duct sign as well, right? So just hold on. Okay, let us see the double duct sign as well. Okay, so if you are going to see an image of the double duct sign, guys, you will see in this case you are seeing dilatation of the common bile duct, and you are seeing the dilatation of the pancreatic duct as well. So in double duct sign we are going to see dilatation of both the common bile duct and the pancreatic duct. But here in this case, guys, we are just able to see that there is fusiform dilatation of the common bile duct. ठीक है, common hepatic or bile duct. So this is the case of choledochal cyst. Okay, so guys, if we discuss the various types of choledochal cyst, so what is type 1? What is type 1 choledochal cyst? Anyone? What is type 1 choledochal cyst? Type 1, there is fusiform or saccular dilatation. Fusiform or saccular dilatation is seen of the common bile duct. Okay, common bile duct. In type 2 guys, what is going to happen? There is a diverticulum. Which is going to arise. Okay, diverticulum is going to arise from the common hepatic duct. In type 3 guys, we are going to see dilatation of only the distal part, and this is known as choledococele. In type 4a, we are going to see dilatation of both the intra as well as extra hepatic bile duct. ठीक है, and guys, in a type 5, what we are going to see in type 5, 4b, there is dilatation of just the extrahepatic biliary system. In type 4b, there is dilatation of just the extrahepatic biliary system. And in type 5, guys, in type 5, we are going to see that there is dilatation of only the intra. In type 5, there is dilatation of only the intrahepatic biliary radicals. ठीक है, and the case in which we are going to see dilatation of only the intrahepatic biliary radicals, guys, that will be a case of anyone? That will be a case of Caroli's disease. And what is the surgery that we are going to do in Caroli's disease? It will be your Kasai procedure. Right? So this is how your Caroli's disease is going to look like. You are going to see multiple hypodense cystic lesions. Will be seen within the liver. ठीक है? So, and you are going to see dot within a cyst sign. Okay, dot within a cyst sign, and this is your portal vein. This dot within this cyst, this is your portal vein radical. Right? So this dot within a cyst sign, this is seen in a case with Caroli's disease. Dot within a cyst sign is seen in a case with Caroli's disease. Right? Is that clear to you guys? Okay. So now guys, moving on to the next question. Next image, guys. Moving on to the next image, guys. What are we able to see in this image? Anyone guys, what are your observations for this image? What are your observations for this image, guys? What are your observations for this image? So again, patient presented with pain in the abdomen. Okay, pain in the abdomen, right? And this pain in the abdomen, it was radiating to the back as well. ठीक है? So this pain in the abdomen, it was radiating to the back, and a CCT abdomen was done. For this patient. Okay. So what are you able to see in this case? What are you able to see in this case? Okay, anyone guys, what are you able to see in this case? So guys, this is a case, okay, this is a case in which I'd shown you the pancreas, the normal appearance of the pancreas, the normal appearance of the pancreas. So guys, in this case, what we are able to see, we are able to see the non-enhancing areas within the pancreas. We are able to see non-enhancing areas within the pancreas. Okay, so these non-enhancing areas within the pancreas, it is pointing towards necrotizing pancreatitis. Okay, this was a case of acute necrotizing. So these non-enhancing areas, these are pointing towards necrosis. Okay, and this necrosis within the pancreas, this will be a case of acute necrotizing pancreatitis. Okay, so guys, these were the few important images from the section of hepatobiliary radiology. Okay, now what we are going to do, okay, now I am going to discuss with you few important images from the section of gastrointestinal radiology. Okay, now I'm going to discuss with you few important images from the section of gastrointestinal radiology. Okay, ready guys? Ready, Dr. Nimisha, Dr. Teja, Dr. Dr. Vidyananda? Ready? For the important spotters? So guys, beginning with the first barium swallow image. Okay, barium swallow image, which is done for the esophagus. Okay, done to look for any pathology in the esophagus. So in this image, we can see that there is a linear defect can be seen. Linear filling defect can be seen at the cricoesophageal junction. Okay, so okay, so this was a case of esophageal web, and the question that has been asked to us is that this following sign is associated with which syndrome? This following sign, it is associated with Plummer-Vinson syndrome. It is associated with Plummer-Vinson syndrome, right? It is associated with Plummer-Vinson syndrome. Okay, and we can also see iron deficiency anemia in these patients. Iron deficiency anemia can also be seen in these patients, right? So moving on to the next question. Okay, next barium swallow image. Guys, what are you able to see? A patient presented with halitosis and regurgitation and dysphagia, regurgitation of food. Okay, so what is your diagnosis for this case? Come on guys, what is your diagnosis for this case? What is your diagnosis for this case? So a barium swallow image is being shown to you. Okay, in this barium swallow image, the patient has history of halitosis, dysphagia. What is being shown to us in this barium swallow image? We can see that there is a diverticulum arising from the posterior wall of the esophagus. Okay, there is a diverticulum arising from the posterior wall of the esophagus, which is a pseudo-diverticulum. Okay, pseudo-diverticulum, because there is herniation of only the mucosa and the submucosa. And guys, this was the case of Zenker's diverticulum. This was the case of Zenker's diverticulum. Okay, so in which there is herniation of mucosa and submucosa through the cricopharyngeus and thyropharyngeus muscle, between the gap between the cricopharyngeus and the thyropharyngeus muscle. Guys, if you are seeing a similar diverticulum, if you are able to see a similar diverticulum on the lateral aspect of the esophagus, guys, then it will be a case of Killian-Jamison diverticulum. Then it will be a case of Killian-Jamison diverticulum. ठीक है. Now other few important spotters from the barium swallow images. Few important spotters. So guys, this is an image showing corkscrew type of esophagus. This is an image showing corkscrew type of esophagus. This corkscrew type of esophagus, guys, this is seen this corkscrew type of esophagus, this is seen in a case with diffuse esophageal spasm. This is seen in a case with diffuse esophageal spasm. Okay, then guys, worm-like filling defects in the esophagus. This is seen in a case with esophageal varices. And transverse bands within the esophagus. This is seen. This is called as feline esophagus. And guys, this feline esophagus can be seen in eosinophilic esophagitis. Okay. It can also be seen in gastroesophageal reflux disease. Can also be seen in the gastroesophageal reflux disease, right? So guys, here in this case, what are we able to see? We are able to see again filling defect in the lower part of the esophagus. This was the case of Schatzky ring. Okay, Schatzky ring. Okay. Now in this image, two characteristics images. So in the first image, both these images, patients presented with dysphagia. So in the first image, the dysphagia was more for liquid. In the first case, the dysphagia was more for liquid than for solids. And guys, in the second case, the dysphagia was more for solids than liquids. Okay? The dysphagia was more for solids than liquids, right? So guys, in the first case, we can see that this barium swallow, we can see that this is a bird's beak appearance. Okay? And this bird's beak appearance, guys, it is seen in a case with achalasia cardia. Okay? And in the second case, guys, we are getting this rat tail appearance. Okay? No, this is not a case of hiatus hernia, Dr. Vidyananda. So this is the case of esophageal carcinoma. Okay, so hiatus hernia has a characteristic appearance, Dr. Vidyananda. Okay, let me just show it to you. Okay, in hiatus hernia, guys, you are going to see, a radiolucency can be seen in the retrocardiac region. Okay, radiolucency can be seen in the retrocardiac region. Okay, so this is a spotter that is very frequently asked in radiology. Okay, so guys, this is your chest x-ray, and in this chest x-ray, guys, we can see that there is a radiolucency. Okay, there is a radiolucency just behind the heart. Look at this image as well. Okay, in this image again, we can see air fluid levels behind the heart, air fluid levels behind the heart. Okay, so this is how you are going to identify a case of hiatus hernia. This is how you are going to identify a case of hiatus hernia, right? Now guys, moving on to the next image. Okay, what are we able to see in this image, guys? What are we able to see in this image? Anyone? Anyone, guys? So nutcracker esophagus we have already seen. Okay, diffuse esophageal spasm. Okay, this is how your nutcracker esophagus, okay, it will look like. This is how your nutcracker esophagus will look like, right? Now guys, in this image what we are able to see, okay, we are able to see that there is coiling of the NG tube. Okay, there is coiling of this NG tube. So guys, can you tell me what will be the reason behind this coiling of the NG tube? What can be the reason behind this coiling of the NG tube? Anyone, guys? What can be the reason behind this coiling of the NG tube? Anyone, guys? What can be the reason behind this coiling of the NG tube? So guys, before I move further, before I tell you the answer for this case, okay, so I am going to discuss with you few important things that are going right now on the Unacademy platform, right? So so guys, we have this few tests that are coming up, okay, which you can attempt. So guys, you can go for this test. You can go for this test by Suman Mana sir. That will take place tomorrow at 7 p.m. and 30 p.m. Okay, you can use my code. Dr Himanshu Life. You can use my code Dr Himanshu Life to take this test. So we have this all India mock test for NEET PG 2022 that is coming up on 1st May. Guys, you can try to attempt this test as well. Okay, you can try to attempt this test as well. Okay, and we have this Unacademy goal, okay, where we are giving this 20% off on all subscriptions. 20% off on all subscriptions is being given to the students, right? So guys, we have this iconic subscription in which if you are a final year or a third year MBBS student, okay, you can go for this iconic subscription in which you will get the best of the Unacademy as well as Prep Ladder. We have also made a NEET PG previous year question bank which you can attempt, okay, in which you are just going to find the previous year questions, okay, and we have a batch coming up on frequently forgotten volatile topics and emergency medicine by Dr. Siraj MH, Shanmuga ma'am, Neha Taneja ma'am, Pradeep Pawar sir, right? You can go for these things. So now guys, coming back coming back to the images, right? So guys, what was this case? You can use my code Dr Himanshu Life, right? Okay. So guys, in this case we can see that there is coiling of the NG tube. There is coiling of the NG tube can be seen in this case. Okay, coiling of the NG tube can be seen. And guys, this coiling of the NG tube can be seen in a case with tracheoesophageal fistula. Can be seen in a case with tracheoesophageal fistula. Okay, in which you are going to find proximal atresia with distal tracheoesophageal fistula. So Vidyananda, can you help me with the diagnosis for this case? A patient presented with epigastric pain, postprandial fullness. Can anyone help me with your diagnosis for this case? Not audible? Can you help me with the diagnosis? So guys, in this case we are able to see a retrocardiac lucency. The patient presented with epigastric pain, postprandial fullness, and in this case we can see that there is a lucency in the retrocardiac area. Okay, so this is a case of hiatus hernia. Okay. So guys, this was all for today's lecture. Right? So we will again meet tomorrow at 6 p.m. with few more interesting images from the section of MSK Radiology. So till then guys, bye bye, take care, and keep working hard. All the best.